The local lecture is going to lead off with Professor Kim Burchiel, who is going to talk about, again, the diagnosis, eh? Is it TN, and can MVD cure it? Kim.
Well, again, I want to thank Chris for doing this. This is a tremendous effort. I know how much work he put into this and his staff, and we all should appreciate that, so thank you. I'm going to try to go pretty quick and hit what I think is new information, new knowledge, but all of it is respectful of the past and the shoulders of the giants that we stand on, Dandy, Janetta, Gardner, et cetera. But also respecting the fact that knowledge didn't stop in 1970, 80, 90. It continues today, which is why we're here talking and exchanging information. So I'm going to go reasonably quickly. Let's see if this is going to work. It's not advancing. Not advancing. Oh, are you just going to dance for me? I guess so. So, oh, wait a minute. Oh, I'm sorry. It started to advance. Can you back it up? This is well into the talk. Keep going backwards. It had a lag there. Okay, let's go. Now it'll work. Okay, so here's what I'm going to do. Very briefly, talk about diagnosis. Again, this is number 1, 2, and 3 on my hit parade in terms of dealing with patients. Wrong diagnosis, wrong therapy, no matter what we do. Surgical treatment, I'll mention briefly because I don't really have to in this audience. Significance of compression, we already heard from Stina earlier today, and I mean, her work in 2015 was really a landmark, I think, in terms of our understanding of what neurovascular compression means. We'll talk about surgical treatment without neurovascular compression. We've heard a little bit about that already. And then I'll get to some pretty new and exciting stuff about the genetics of trigeminal neuralgia. So again, getting back to classifications, we've had old classifications which weren't very helpful. Atypical trigeminal neuralgia, we still sort of deal with that term. We called it type 2, but what that means is still, really a problem. So this was our classification. More than 50% episodic was TN1. More than 50% constant was TN2, or the atypical forms. I hate to say it, I'm having my doubts about that classification right now, although it's been a useful vehicle for me anyway to understand what's happening. And then we have a long list of other things which cause facial pain we're not going to talk about. So one of the concepts behind the TN1 and TN2 was, with progressive neuropathy, does the pain become more like neuropathic pain elsewhere in the body, which is constant, burning, and it doesn't have the episodic quality of trigeminal neuralgia, in that trigeminal neuralgia is pretty unique in that one area. Does that happen? Well, I actually think that doesn't happen very often. I think it happens with repeated lesions, like in an MS patient, we do radiofrequency lesions, and time after time, their pain gets a little bit less and less typical, although they still have episodic pain. The bigger problem is related to other, more common, or much more common etiologies for facial pain, particularly what falls under the rubric of temporomandibular disorder. And I hate to say that because I'm not a dentist and I don't understand this fully, but most dentists don't want to talk about this, don't understand it, don't treat it. It's a pretty big problem and it's very common. It's probably between 100 and 1,000 times more common than trigeminal neuralgia. So the prevalence, at least in the statistics I've found, is about 7 to 12% in the world. The incidence of TN, that's the wrong word. Incidence is about 0.01 to 0.02 per year, but I just looked at a Korean study, and it was a great study looking at the prevalence, and it was about 0.1%, so 10 times more, but still pretty rare condition. But forgetting that, TMD and its associates are well more likely than TN for the next person that walks in the door with facial pain, even episodic facial pain. It can mimic trigeminal neuralgia in many important ways. My problem with the diagnosis for years was I always thought it must be the joint. You hear about patients, I got worked up for TMJ, they told me my joint's fine, so that eliminates that. Turns out TMJ is a rare cause or uncommon cause of facial pain. It is part of the TMD spectrum, but it's by far not a requisite. So the pain is in the muscles of mastication. And this is something that neurosurgeons do not know unless somehow you've been introduced this in some other way. This is pain that you can determine on exam, which is why an in-person examination is really critical. But pain in the temporalis muscle, pain, and the insertion of the temporalis on the coronoid process intraorally, almost pathognomonic for this problem. Masseter tenderness in the posterior ramus of the mandible. It takes you about 2 minutes to do this exam, but if you see those features, stop. You're probably not dealing with trigeminal neuralgia. The pain can radiate into the distribution of the trigeminal nerve, particularly around the eye and into the cheek, even sometimes down the jaw. And it is episodic. I've watched patients have this. They appear to have a bout of tic douloureux, grabbing their face and stopping, the way we normally expect trigeminal neuralgia to behave. The difference is that patients with TMD have a baseline pain, usually pretty significant, 3, 4, 5 out of 10. If that is the patient you're looking at, stop. That's not trigeminal neuralgia. It's something else that is now mimicking TN. So we don't have time to go into all the detail here, but I would just advise you to think about it and maybe delve into it a little bit more. Find a colleague that can help you diagnose these folks. And that's hard to do, by the way, because many of the features, bouts of pain are quite typical, but they have that baseline pain. So if you look across these two columns, many of the features of TMD are what we see in trigeminal neuralgia. Episodic pain is a feature, clearly, but it's on a chronic background that effectively never goes away. And it's not a 1 out of 10, it's a 3, 4, 5 out of 10. Anticonvulsants is, so chronic pain, number 1. Number 2, anticonvulsants don't have a profound effect. If you ask a patient, did the carbamazepine help? Did the gabapentin help? They will say, oh, yes, it helped. Well, how much? Well, 10%, 15%, 20%. It's not the dramatic cessation of pain that we see in most patients with trigeminal neuralgia. So those are the 2 most important features to consider. You can diagnose trigeminal neuralgia over the phone, but you need to see these people and examine them. There's no substitute for the exam. And the problem is down here, temporalis fan, the posterior ramus of the mandible, intraoral, touching just where the coronoid process is, the patient will recoil, just a light touch. Masseter, all those muscles, you need to look at the bite. We often make them bite down on a tongue blade, and if they just won't bite on that side, that's my agonizing pain, that's my familiar pain, that's probably what you're dealing with. So exam is a must. So diagnosis. It's the most important thing. This problem of TMD can be easily confused, and I see it happening all the time with neurologists. Pardon me if there's any neurologists here, but it happens all the time, and these people are treated for years and years with the wrong drugs and to no avail. It's easily confused and is. As I said, you can listen to a patient talk for 2 minutes and they'll tell you they have trigeminal neuralgia, but TMD, you have to examine them. And we're in the process, we have a little mini exam. It takes about 1 minute to do. I'm going to publicize that, and I think it's something to sort of every neurosurgeon that deals with trigeminal neuralgia should at least know what to look for. Should be strongly considered, only on a statistical basis, because it's 100 to 1,000 times more common than TN. When you have atypical TN, you should think about it. So surgical treatment, again, I'm going to go through this real quick. This is the Cochrane statistics published by Joe in a few years ago. Basically, whoops, sorry, back up here. Let me go back. Okay. MVD clearly wins. That's this orange line. The thing that I must admit bothers me when I see these lines flatten out, I haven't seen that. That's not the data we published 20, 30 years ago. It continues to decline at about a 4 to 5% rate per year, but it still is the winner. And whatever we're doing, as we talked about with Stina, we may be doing a little manipulation of the nerve, a little microlysis, but whatever it is, it's working. So let's not forget that this is a big success story, and that's what we owe to Peter and Gardner and others. If you look at the other things, radio frequency, helpful, probably a half-life of around 4 to 5 years. That's my favorite procedure. Glycerol I did for years, but it doesn't last quite as long, and it is a more, I believe, more difficult procedure. And balloon, that's kind of not been a big part of my practice ever. I've done it a few times, not super helpful for me, but so the RF gangliolisis, that's my go-to, and I do think if you're going to treat with MVD, you should have another procedure, either probably one of these percutaneous Hartle-type technique procedures. I'm not sure that radiosurgery would count, but that's at least an alternative for the patient. But I think the dedicated neurosurgeon that's interested in trigeminal neuralgia should have one of these percutaneous ablative procedures that they're mastered. I think that's really, really important. And you know how that works, going through foramen ovale. This is the whole point of this conference with superior cerebellar here, which I find in almost every case. So when you see this, this is our meat and potatoes. I mean, superior cerebellar frequently duplicated under the nerve, creating more crowding. You drag that out of there and, pretty easily. And then at least what I do, and some may have better ways of doing this, I put Teflon between the nerve and the vessels, and I really think this is what Janetta described, and that's basically what I've done. And our outcome data is based on this. I don't do a sling. I know I've talked to Ludwig, and he does a different procedure, and there may be work to do on that to show if that works better. No one has shown that yet, as far as I know, but it kind of makes sense. So this is the so-called decompression procedure. Again, I may be arguing against myself, but if this was a lumbar disc, we wouldn't consider this to be decompressed if that was the nerve root. We've just introduced compression. This gets to the point of why does MVD work? Is it a chronic injury model, for example? And that's not the first time this question has arisen. There's a guy, CBT Adams, who Ludwig, I've talked to CBT Adams, he's still alive, and we've exchanged back and forth and talked, and we even did a video conference together. I don't think this idea is dead. I think there's still an issue here that we might be producing a chronic injury, and that's why MVD works. And I won't say much about it, but this is his idea, and I think it's still worth considering that we're producing trauma either during dissection and decompression, but maybe there's probably the gift that keeps on giving in terms of that piece of Teflon in there. The evidence that microvascular compression, neurovascular compression, produces trigeminal neuralgia is actually pretty weak. This paper, 2013, not very convincing data around that. This is Stina's paper from 2015. Again, the important point with her is that the simple contact, if radiologists were asked to vote on the side of the neuralgia based on a grade 1 contact, it was a coin flip. They couldn't do it. Now, if they had the CINDU grade 2 or grade 3, that is compression or distortion, now we're talking. We had much higher rates of positivity there. So it looks like, at least in this case, the severity of compression has a lot to do with the potential that this is a neurovascular syndrome, since severe compression is highly associated with TN as opposed to neurovascular compression in general. The problem is this is Mark's scale, which I've used, 1 being contact, 2 compression, 3 distortion. It's these 2 that Stina considered to be she considered this the severe compression category. So those are the ones she was talking about. Now, again, with all love and affection for Mark, one of my heroes, I think compression, at least in our hand, is almost entirely arterial. I think it does occur. We've published pictures. I think Jonathan showed a couple of those, where the vein clearly distorts the artery. I think those are unusual cases. I also think, as Mark demonstrated, once you start fooling around with big veins along the brainstem, you're in tiger country. I think I would be very hesitant to do that, and I probably would still just do an internal neurolysis if I saw one of those, but I haven't seen one for a while. So, but notice there's a mixed bag here in the patients with no vessel. You get all kinds of things in the vicinity, but not etiologic. Here's one of the interesting little statistical things, and Jonathan made this point a different way. a percentage of adults have neurovascular trigeminal compression. We did that work when he was a fellow. We looked at an age match control series, and it looked like, I think it was 17%, but it doesn't matter whether 14 or 17 or 70. The commonality of type 1 neurovascular compression is so great. It means that 99.94% of individuals with neurovascular compression, grade 1, don't have trigeminal neuralgia. So how can we can even ascribe that etiologically to the disorder? I think, again, that comes back to Stina's work showing it's really severe compression, which is not nearly as common as the grade 1. In general, the general population, neurovascular compression is meaningless, which is why, I don't know about you folks, but when I see a patient that's newly diagnosed as trigeminal neuralgia, the first thing they show me is their MRI. Well, my doctor said, I have trigeminal neuralgia because you have this vessel next to the nerve here. Let's talk about your pain a little bit before we go to the MRI scan. Now, this is what we all like to see. This is a superior cerebellar artery. We can decompress that quite nicely. Patients are happy. That gives you a good outcome. One of the issues is, why does that continue to go downhill over time? I would submit probably because we're producing some chronic ongoing injury, and eventually trigeminal neuralgia, which is a progressive condition, catches up with that neurolytic effect of MVD. So what about recurrence? Well, recurrence, at least in our hands, had nothing to do with the artery. This is pretty typical. We had a big superior cerebellar here. We had, Teflon here. Now you can argue maybe if I sling that, away from the nerve completely, it wouldn't happen. Prove it. That would be my answer. So what we do here, I'll show you in a bit, is for recurrences, we'll do this internal neurolysis procedure. So again, one of the big problems with MVD is why, if we've cured it, why does it ever come back? Let's see here. Then the other issue is, what about the no neurovascular compression? And I think when I see things like arachnoid adhesions, veins, other things being invoked, I think if you're committed in almost a religious way to neurovascular or vascular compression or neural compression, you got to find something, because that's the problem. I think it's ignoring the fact that it might not be compression. There might be another explanation for it. So we see this all the time, and I will go into detail about this. One of the things that came out when we did this analysis, actually Andrew Coe, one of our fellows, looked at this, and there was a clear distinction between patients, how they presented without neurovascular compression and with neurovascular compression. This is without, this is with, this is age. Clearly they presented earlier with no neurovascular compression, and almost if you do a normalized distribution, there's a clear peak at a young age. So why is that? When you also look at the age of the patient and the presence of no neurovascular compression, it goes steadily down from the 3rd, 4th decade to the 8th, 9th decade, steadily down to almost nothing, whereas vascular compression goes up. Clearly, we think vascular compression is a problem of tortuosity, and that accrues over age, so that kind of makes sense. But there's a whole problem here of why does this ever happen if there's no vascular compression, and I hope I'll have an answer for you here shortly. So these are the two curves. There's a big overlap, and this is no neurovascular compression, this is vascular compression. But notice this curve goes well out into the 8th, 9th decades here. So it's not simply a problem of young people. We see it in the older patients too. Here's the issue, the thing that triggered a big study that I'll mention at the end here. The no neurovascular compressions are almost entirely female. This blip of males, I think if I were to redo the statistics now, that would be on the baseline, almost nobody. In other words, there appears with a strong female predominance of no neurovascular compression, which may in part explains why females have always been a greater proportion of the population with trigeminal neuralgia, because no one's explained that till now. So this is what we see, the no neurovascular, here's the, obviously there's nothing around here. Trust me, I don't think, there's a suprameatal tubercle here, which I know some people are drilling out, which I think is a really bad idea. Anyway, we can't see the porous trigeminus, but we can see right up to the brainstem, there's nothing there. So that patient, we will do what I've called this internal neurolysis, which is just an older version of a stripping procedure that used to be, was a subtemporal tick, basically, back in the turn of this 20th century. And one thing, if you haven't done this, I'll warn you, be careful. You can get profound bradycardia. tell the anesthesiologist before you start, you may see some slowing here, because if you jump right in there, you basically see an entire sweep of an EKG with no QRSs, and then you have to jump over the ether screen and resuscitate the anesthesiologist because they've now fainted, they've called a code or whatever they've done. So pre-treat with glyco or atropine, or just be aware. And it can happen, in some patients it happens profoundly, in other patients not at all. And I suspect that has to do with the vagal tone and the vagal system in general. So, and I do the same thing as I mentioned with a recurrent MVD. I don't go in there and, because if you remove that Teflon and do all this, you've produced a neurolytic procedure. You've traumatized that nerve. I'm going to go ahead and just do that on purpose. By the way, when you do this on a virgin nerve, like the one I showed earlier, these patients have some numbness briefly, but that goes away. They have almost no permanent hyposthesia. You do it on someone that's had an MVD, essentially the same procedure, very numb. Tells me there's a cumulative injury in that nerve. We're just adding to it, but I don't have great quantitative data on that. So when you look at the outcomes, and this is something we were talking about yesterday, Ludwig, the outcomes from internal neurolysis are pretty close. This is basically it's comparable to the total recurrence rate for MVD over time. So these are old statistics. This is our newer statistics. So it's strange that you can reproduce the effect of MVD by that combing procedure. Okay, now to the fun stuff, which is not published, by the way. So this kind of made us think there's got to be a genetic element here. Why would all the females have no neurovascular compression? And Jonathan did mention some of these imaging abnormalities that are present often on bilaterally, and I know Moji has done a lot of this work. Why would that be? So we started a study. This is now 8 years into this study. We ended up with over 1,000 patients. Actually, this number is over 1,000, and we got more controls now. And using modern techniques of both genome-wide association study, GWAS, and also whole genome sequencing. The GWAS was performed on every patient, and Moji was a part of that. Pittsburgh was a part of that. I don't know if anybody here, I think we had 6 centers in the United States, and Joanna Zakcheska was also part of the study. So they all contributed patients. And the patients had to have what we call TN1, both by that online questionnaire, but also by the physician's impression and diagnosis. So it had to have both of those, which is a pretty, I think, highly purified population. This has to be done by populations, in both not only just Caucasian, but we've just recently looked at data, for example, in Finland. Are there any Finns here? Finns are genetically different. They don't fit the Caucasian model, and I guess geneticists know this. But we looked at UK Biobank, and I'll mention that at the end. So you have to do, this is sort of against diversity and equity and all every other thing. But the fact is you cannot look at these, large numbers of control populations which are available and compare different ethnic populations. So it's all Caucasian. And then I mentioned we had a dual qualification for the study. So I'm really compressing a lot of work into a couple of just interesting findings. I mentioned the work with the females showing they were almost exclusively represented the no neurovascular compression in younger age. We looked at those two curves that I showed you, and the crossover point was about 45. So we just arbitrarily said, okay, 40, and I apologize, any female over 45. I'm not a youthist. I think we have plenty of reason to respect everybody over 45, but that's what we used. And we looked at, whoops, that's not what I wanted to do. Back up here. Oh, I see. Am I going backwards? No, that's it, sorry, I apologize. Okay, so here's what we found. There is a GWAS peak around the BDNF gene region. And it's in the regulatory region of BDNF. And that's the sole thing that we found by GWAS. It just stood out in the data. And it was strictly young females, which to me validates the idea that we clinicians have something to offer basic scientists, in this case, a geneticist whose methodology is so far above my head, I couldn't begin to tell you. But I suggested, look at this population based on my experience and based on the data, and this fell out of it. So it appears there are single nucleotide polymorphisms in the BDNF region, which is regulatory, and it's an unusual mechanism. It's called antisense, and there's 2 different antisense genes that this is affecting. So we now have almost a genetic marker, we think, for these young females that don't have neurovascular compression. We haven't converted this into a laboratory test. This is all unpublished, but we hope this will eventually become a methodology that's used in so many other conditions we face in medicine, where we can now do genetic analysis to determine what is the actual origin of this. Do they have these antisense mutations, or don't they? And I should say, I mentioned that we now compared a like population in Britain from the UK data biobank. They had about 500,000 people or so. I think they had somewhere around 400 patients that were alleged to have trigeminal neuralgia. We just basically threw that against the wall and said, do any genes pop out of that that were similar to a list that we had? And the one that popped out, BDNF. So BDNF is increasingly more likely to be the origin. This is the so-called Manhattan plot. This is the BDNF peak there. This is basically expanding that plot. And this region, this is a regulatory region of BDNF, shows multiple genes. It's the ones at the top. Because of the multiple comparisons problem with this type of analysis, you're talking about 25 million comparisons. You're looking at P's values of -7, -8. So that's why only the ones on the very top of this are probably significant. So strong evidence right now, both based on our data and now with this comparison to the UK Biobank, that BDNF plays a role in a large number of, well, in our case, seems to play a role in the development of trigeminal neuralgia, but it also plays a role in a growing list of conditions, including inflammatory demyelinating polyradiculopathy, Alzheimer's, Huntington's, Parkinson's. And we can, in a way, benefit from the research in those areas because it opens up a whole new line of therapy. And this has already been tested now in preclinical work of looking at BDNF inhibitors and other things. So it's an approach that's never been looked into in the past. So I mentioned too that we've now done 100 whole genome sequencing on a sample of these patients. And this is much more expensive stuff to do, so we're kind of run out of money at the moment. But we've looked at this, and what emerged from the whole genome sequencing was that mutations related to myelin, which is what we've always thought was going to be an issue, also to the epilepsy seizure package. So you look with WGS, you can ask a question about keywords, and it falls into these 2 categories. And that we found, that's what this shows. These are the young females. Again, didn't show the, weird, that doesn't have the baseline. Anyway, this is the myelin, this is seizure, and that's the young females. So they clearly stand out from the pack. So this is another way to think about this, is it appears to be myelin mutations in those younger females. Now, lastly, I want to mention, we're here about vascular compression. So what we did was we took 132 patients that were already in our data bank from our international study, 89 of which had neurovascular compression and 43 did not. And this was analyzed by my fellow 2 years ago. I had nothing to do with it. He just looked at the videos and looked at the neuroimaging and basically said, this is grade 1, grade 2, grade 3, grade 0. And so we used all the information we had, graded the vascular compression on the Sandu scale, and then we already had the data. We just had to pull that data for the outcome. And basically what we found was these 7 SNPs jumped out at us. little complex to look at this, but I'll just describe to you what this shows is there's an association. And it turns out that these 5 are present in our patients that had neurovascular compression. They were substantially significant in our population. And if you did not have neurovascular compression, you had those +2. So this is sort of the 5 + 2 theory. What it says is that neurovascular compression exists as a cause of trigeminal neuralgia, as a predisposer for the development of trigeminal neuralgia, that it's not any genome that can do this. It requires specific mutations to lead to the development of this common phenotype of trigeminal neuralgia, whether you have vascular compression or don't. I think that's going to require a lot of replication, but that will be published hopefully soon. These are the SNPs that were involved. I can't even tell you what they do. So again, this is the 5 + 2. Again, if you have patients with grade 2 to 3 neurovascular compression, had variants in 7 SNPs, but the 2 out of the 7 were present in a highly significant way on the patients without neurovascular compression. So my final slide or two, what we call trigeminal neuralgia, in my view, is in fact a common phenotype, but it has multiple origins. I think we've described, or close to describing, a young female population with a BDNF antisense mutation, but I think we're going to see that as a foundation of what will be a list of other genetic predispositions for trigeminal neuralgia. So we have a patient population that's generally older that has neurovascular compression, younger that doesn't and that has a BDNF mutation. MS, of course, we know. Again, these phenotypes are all the same. These are very different problems. And of course, the rare tumor and vascular lesion. These are not common, but they can produce the same issue. The risk of development of TN1 may, in fact, ultimately be determined genetically. Female gender certainly suggests that. Neurovascular compression data that we have certainly suggests that. And TN1 appears to occur on the background of a genetic predisposition of that I've described, the 5 + 2. Multiple lines of evidence argue that neurovascular compression is not required in all cases for the development of trigeminal neuralgia. There's strong evidence that we've now developed that there's a genetic predisposition for the development of it with and without neurovascular compression. Again, not to denigrate MVD, it's still the first choice for reasons that we still don't think we fully understand. It's a phenotype. TN is a phenotype. It's not a disorder. It's not a monolithic disorder. That's all I have. Thank you very much, Chris.
Thanks, Kim. It's a really nice presentation of the science. Just a couple of basic questions. Yeah, I agree with your kind of conclusion at the end that trigeminal neuralgia is like epilepsy. Not all TN is the same, and epilepsy is not all the same.
That's right.
And there are multiple mechanisms that produce the same phenotype and clinical picture. So I think it's a really fair parallel, as much as the reason that the medications work similarly for both categories of disease. Second question, what are the SNPs in the normal patients with neurovascular compression? So you looked at the patients that have symptomatic TN with vascular compression, and they have incidence of SNPs
They have
5 and 2
variants that are statistically significantly elevated.
Right.
Correct.
What is that 5-2 number, not 5-2, in the patients who have neurovascular compression that don't have TN? Because you have a large population of those.
Well, these are being compared to a control group that doesn't have TN, so that's where the statistics derive. I'm not sure what your question is.
So when you compare that was compared to patients with neurovascular compression but not TN.
No. It was compared to a control group that we don't know anything about the baseline neurovascular compression. These are controls that are available widely that we just derived.
No, that's what I'm looking for.
Yeah.
A set of controls, quote unquote,
don't know.
that have vascular compression.
Great.
And what's
Great. And it depends on then how you define compression.
Well, that's whatever you use for your
that's
category
work,
of TN
again,
patients.
Right, and what worked for the future. That's a huge question. What if you have grade 2, 3 compression And if you don't have those genes, do you not develop it? I mean, that's an open question, if that's what you're asking.
And that last quick question is,
Yeah.
you didn't like drilling off the tubercle, you call it the protuberance, the osteoma, the endostosis. Why did you think it was a quote-unquote bad idea?
I just think MVD is a very straightforward operation. It is mostly very uncomplicated, and I think as soon as you start drilling away, and you, I'm sure, we've all seen these massive tubercles. So I'm very wary of that idea of getting in there with a drill and starting drilling around. You're right around the porus acousticus, and
Wait 5 presentations.
Say what?
Wait 5 presentations.
Okay, good, thank you. Yeah, look, sir. Sure. Yeah.
Turn that on? Okay, great.
Yeah.
Kim, thanks for a phenomenal presentation. I must say, I'm very grateful to you because you're one of the few physicians that's changed my practice in terms of treating trigeminal neuralgia and in terms of neurolysis.
I couldn't be
and whatnot.
happier.
So I think that's a really good sign. I just want to come back to you on whether we leave Teflon in touch with the nerve loop or not.
Yeah.
The reason that I don't do that is a paper by Mark Sindhu back in 2008, where he took 330 patients and looked at those where the Teflon had contact and where the Teflon didn't have contact.
Yeah.
And there was a much greater, I think about 15% difference in terms of the long-term outcome of pain freedom in the ones where there was no nerve contact with the Teflon versus the ones without.
Okay.
So again, these weren't randomized controlled patients, but I try and learn from the people who came before me, and that's the only reason I take that approach.
No, I mean, I can't argue against it. I just think it is a more elaborate operation. You described to me what sounded like a pretty simple, slick technique. I think you should patent that and make everybody pay you a little bit every time they glue that thing up. But I think that's still one of those open questions. Is that a better operation?
I'd agree.
And you could look at it both ways, as we discussed yesterday. If you just do that and don't even touch the nerve, and you're honest, I know you're honest, that might have a worse outcome. I don't know. I mean, we don't know the answer, but it's certainly an area for the younger people here to explore.
And again, coming to your point of the genetics and learning that this isn't one disorder, which is something I think that's really important, because outcome is probably going to depend on not just on what we do, but even more so on the patients we select, and knowing the genetic background of these patients is going to make a big difference.
I think we're going to have some levers that we never had before in terms of particularly putting it in the hands of neurology to say, okay, I think this person has this, because they love blood tests. So they can do a blood test and boom, or a spit test, and now we have your answer. I mean, I think we've lagged in that area of, specific therapy, patient-specific therapy, but we're now getting closer and closer to that era. We can actually categorize these people and say, well, you have this, we're going to do that. And then we're going to have to look at the outcomes of those. Yeah, thanks.
Kim, 2 questions from Jason Schwab online. First, what do you make of the male-female differentiation when BDNF is not a sex-linked gene?
Well, we don't know where, and hi, Jason. We don't know the derivation of why BDNF seems to be important in females. If that's his answer, or if that's his question, the answer is we don't know. It isn't sex-linked, but it's probably interacting with a whole bunch of things that are. And we know that I kind of emphasize this as a single one that popped up, but we know this cannot be a single mutation, or we'd see pedigrees, we'd see families. We talked about this before. At least in my experience, a pedigree of trigeminal neuralgia is exceedingly rare, exceedingly rare. We hear histories, oh yeah, my uncle had it, my grandfather had it, no, he's passed, but we don't really have the evidence that link those two, which is why anybody, frankly, if you have a pair, a familial pair, super important to get GWAS and whole genome sequencing on that pair, because those findings are pivotal for the genetic mechanism and replication of any kind of linkages, because to see the same pattern in both individuals, particularly if you could have another family member that doesn't have it, would be profound. It's one case can change, is worth reporting. So.
And second question, also from Jason. It looked like you were combing the Burchiel minor in one of the videos. Was he correct about that? And if so, what's your reasoning?
Well, Burchiel minor isn't really a minor. Burchiel minor is half sensory, almost entirely C fibers. It doesn't have a lot of myelinated sensory fibers, but it is not the motor root, as sometimes we call it. It is a sensory root, sensory plus motor.
And there's a question from Dr. Fujimaki. Go ahead, Dr. Fujimaki. I think we could be able to hear
Can you
you.
hear me?
Yes.
Okay. Yeah, actually, I'm almost the same question regarding the person who made the question from the floor. Regarding the recurrence cases with the Teflon between the nerve and artery, because of that, I think you only did the partial kind of nerve lightening, but I think you can move that artery away a little bit, and that will be that might be relieve the pain, in my opinion. Can you get me?
I think that, yes, I do. And I understand what you're asking. You're asking, why not just go in there and do another decompression? My answer to that is you're probably kidding yourself that you're moving the artery away. What you're really doing, you notice in separating that Teflon from the nerve, you're producing injury to that nerve. Mm-hmm. And I figured we either, do it or don't do it, but you have no choice when there's Teflon against the nerve. You are going to damage that nerve. And so I'm trying to produce an injury that will be consequential and lasting. So but I can't prove that. That's my philosophy, though.
Thanks, Kim.
Thanks, Chris.
Next talk is Dr. Ahmed Raz.